Airway and ventilatory management. Q&A Essential General Surgery Questions based on Advanced Trauma Life Support Guidelines. Welcome to our podcast episode on airway and ventilatory management, where we address 100 commonly asked questions based on the Advanced Trauma Life Support Guidelines and critical care principles. Pause when you hear the word answer to attempt answering the question. Let's get started. Fundamentals and assessment question. What is the first step in the Advanced Trauma Life Support Primary Survey? Answer. Airway assessment with cervical spine protection. Question. What is the single most important step in managing a trauma patient? Answer. Securing a definitive airway if the patient cannot maintain their own airway. Question. What is the definition of a definitive airway? Answer. A definitive airway is a cuffed endotracheal tube placed in the trachea and connected to a secure oxygen source. Question. What are the clinical signs of an inadequate airway? Answer. Signs include an obstructed airway with no air movement, stridor, gurgling, snoring, agitation due to hypoxia, cyanosis, and paradoxical chest wall movement. Question. What is the first maneuver to attempt for a suspected airway obstruction? Answer. Suctioning to remove blood, vomitus, or secretions. Question. What simple maneuvers can be used to open an airway? Answer. The jaw thrust or chin lift maneuvers. Question. Why is the jaw thrust maneuver preferred in trauma? Answer. It minimizes movement of a potentially injured cervical spine. Question. What is the most important rule during initial airway management? Answer. One should assume a cervical spine injury in any multi-trauma patient and maintain inline stabilization. Question. How is inline cervical stabilization performed during intubation? Answer. A provider holds the head in a neutral position, minimizing flexion and extension, while another provider performs intubation. Question. What is the most common cause of airway obstruction in an unconscious patient? Answer. The tongue falling back against the posterior pharynx. Basic adjuncts and oxygenation question. What are basic airway adjuncts? Answer. The oropharyngeal airway and the nasopharyngeal airway. Question. When is an oropharyngeal airway used? Answer. Only in unconscious, unresponsive patients who lack a gag reflex. Question. When is a nasopharyngeal airway used? Answer. In semi-conscious patients who may not tolerate an oropharyngeal airway. It is contraindicated if a basilar skull fracture is suspected. Question. What is the preferred method for pre-oxygenation before intubation? Answer. Administration of high-flow oxygen via a non-rebreather mask for 3 to 5 minutes. Question. What is the goal of pre-oxygenation? Answer. The goal is to denitrogenate the lungs and create an oxygen reservoir, thus delaying desaturation during apnea. Question. What is apneic oxygenation? Answer. It is the application of high-flow nasal cannula during intubation to passively oxygenate the patient during apnea. Definitive airway management. Intubation. Question. What is the gold standard for securing a definitive airway in trauma? Answer. Rapid sequence intubation. Question. What are the 7 P's of rapid sequence intubation? Answer. Preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection and positioning, placement with proof, and post-intubation management. Question. What is the goal of rapid sequence intubation? Answer. To quickly render the patient unconscious and paralyzed to facilitate intubation while minimizing the risk of aspiration and coughing. Question. What is a common induction agent used in trauma rapid sequence intubation? Answer. Etomidate is frequently used due to its hemodynamic neutrality. Ketamine is also used, especially in shock, but may increase intracranial pressure. Propofol can cause hypotension. Question. What is a common paralytic agent used in rapid sequence intubation? Answer. Succinylcholine has a fast onset and short duration. Rocuronium offers a longer duration and lacks contraindications in hyperkalemia or burns. Question. What is the Sellick maneuver, also known as cricoid pressure? Answer. It involves applying pressure to the cricoid cartilage to occlude the esophagus and prevent passive regurgitation and aspiration. Its use is controversial as it may impede laryngoscopy. Question. What is the first method to confirm correct endotracheal tube placement? Answer. Direct visualization of the tube passing through the vocal cords. Question. What is the most reliable bedside method to confirm endotracheal tube placement? Answer. Continuous waveform capnography, which detects end-tidal carbon dioxide. Question. What are other methods to confirm endotracheal tube placement? Answer. Other methods include an esophageal detector device, Assessing bilateral chest rise and breath sounds. Absence of sounds over the epigastrium, and fogging in the tube. Question. What is the definitive test to confirm endotracheal tube placement? Answer. Chest radiography, verifying the tube is 2 to 3 centimeters above the carina. Question. What is the danger of a right mainstem intubation? Answer. It ventilates only the right lung, potentially causing the left lung to collapse and increasing the risk of right pneumothorax. Question. What is the initial ventilator setting for a trauma patient? Answer. Assist control mode with a tidal volume of 6 to 8 milliliters per kilogram of ideal body weight, a rate of 12 to 16, 100% fraction of inspired oxygen, to be weaned, and positive end. Expiratory pressure of 5 centimeters of water. Surgical airways. Question. When is a surgical airway indicated? Answer. In cases of failed intubation, the cannot intubate, cannot oxygenate scenario, severe maxillofacial trauma, or airway obstruction not relievable by other means. Question. What is the preferred emergent surgical airway? Answer. Cricothyroidotomy. Question. Why is a cricothyroidotomy preferred over a tracheostomy in an emergency? Answer. It is faster, has fewer bleeding complications, and is easier to perform due to its superficial anatomy. Question. What is the anatomical landmark for a cricothyroidotomy? Answer. The cricothyroid membrane, which is located between the thyroid cartilage and the cricoid cartilage. Question. What are the two main techniques for cricothyroidotomy? Answer. The Seldinger technique, which is needle-guided, and the surgical technique involving scalpel and dissection. Question. What is a contraindication for cricothyroidotomy? Answer. Direct trauma to the larynx or cricoid cartilage. In children under 12 years, it is relatively contraindicated due to small anatomy. Needle cricothyroidotomy is preferred. Question. What is a needle cricothyroidotomy? Answer. Placing a large bore catheter through the cricothyroid membrane which can be connected to a jet ventilator for temporary oxygenation. Not effective for ventilation. Question. What is a key complication of jet ventilation via needle cricothyroidotomy? Answer. Barotrauma and pneumothorax due to inadequate exhalation. Ventilatory management and life-threatening conditions. Question. After securing the airway, what is assessed next? Answer. Breathing, ensuring adequate ventilation and oxygenation. Question. What are the 6 immediately life-threatening thoracic injuries? Answer. Airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and cardiac tamponade. Question. What is a tension pneumothorax? Answer. A one-way valve air leak causing air to accumulate in the pleural space, leading to mediastinal shift, impaired venous return, and cardiovascular collapse. Question. What are the clinical signs of a tension pneumothorax? Answer. Respiratory distress, hypotension, tracheal deviation, absent breath sounds, jugular venous distension, and cyanosis. Question. What is the immediate treatment for a tension pneumothorax? Answer. Immediate needle decompression at the second intercostal space, midclavicular line. Do not wait for radiography. Question. What is the definitive management after needle decompression? Answer. Placement of a tube thoracostomy, also known as a chest tube. Question. What is an open pneumothorax, or sucking chest wound? Answer. An open chest wall defect greater than 2/3 the tracheal diameter, allowing air to enter the pleural space with each breath. Question. What is the initial management of an open pneumothorax? Answer. Application of a 3-sided occlusive dressing to allow air to escape but not enter, followed by chest tube placement remote from the wound. Question. What is a massive hemothorax? Answer. 1,500 milliliters of blood in the pleural space. Question. What are the signs of a massive hemothorax? Answer. Shock with hypotension, absent breath sounds, and dullness to percussion on the affected side. Question. What is the treatment for a massive hemothorax? Answer. Simultaneous large bore intravenous access for resuscitation and tube thoracostomy. Question. What is the indication for emergent thoracotomy for a hemothorax? Answer. Initial chest tube output greater than 1,500 milliliters or ongoing output exceeding 200 milliliters per hour for 2 to 4 hours. Question. What is a flail chest? Answer. Fracture of 3 or more adjacent ribs in at least 2 places, creating a segment that moves paradoxically during respiration. Question. What is the primary life-threatening problem with a flail chest? Answer. The underlying pulmonary contusion, not the instability of the bone. Question. What is the management of flail chest? Answer. Adequate analgesia, such as with an epidural, and positive pressure ventilation if needed for respiratory failure. Difficult airway and rescue techniques. Question. What is a difficult airway? Answer. A clinical situation in which a conventionally trained anesthesiologist experiences difficulty with mask ventilation, tracheal intubation, or both. Question. What is the first rescue technique for a failed intubation attempt? Answer. Face mask ventilation with 100% oxygen using a two-person technique with oropharyngeal or nasopharyngeal airway. Question. What is a supraglottic airway device? Answer. A device that sits in the hypopharynx to provide ventilation, such as the laryngeal mask airway, IGEL, or King laryngeal tube. Question. What is the role of a supraglottic airway in a difficult airway? Answer. It is a rescue device for ventilation and can serve as a conduit for fiber optic intubation, though it is not a definitive airway. Question. What is the role of videolaryngoscopy in trauma? Answer. It is increasingly used as a first-line tool, often providing a better glottic view and reducing cervical spine motion. Question. What is the role of fiber optic bronchoscopy in trauma? Answer. It is excellent for anticipated difficult airways, such as known challenging anatomy or facial trauma. In a stable patient, it is difficult to use in a bloody airway. Question. What is the final step in a failed airway algorithm? Answer. Emergency invasive airway access, that is, cricothyroidotomy. Pharmacology. Question. What is the advantage of using etomidate for rapid sequence intubation? Answer. Hemodynamic stability, as it typically does not cause hypotension. Question. What is the disadvantage of etomidate? Answer. It can cause adrenal suppression, which is a concern in septic patients. Question. What is the advantage of using ketamine for rapid sequence intubation? Answer. It provides dissociative anesthesia, maintains blood pressure and respiratory drive, and acts as a bronchodilator. Question. What is the disadvantage of ketamine? Answer. It can increase intracranial pressure and is contraindicated in patients with significant hypertension or active psychosis. Question. Why is succinylcholine contraindicated in burns older than 48 hours and major crush injuries older than 48 hours? Answer. It can cause life-threatening hyperkalemia due to upregulation of acetylcholine receptors. Question. What is an alternative to succinylcholine in these cases? Answer. Rocuronium at 1.2 mg per kilogram for rapid sequence intubation. Special considerations. Question. What is the minimum Glasgow Coma scale that typically requires intubation for airway protection? Answer. A score of 8 or below. Question. How does airway management differ in a patient with suspected basilar skull fracture? Answer. Nasal airways, nasogastric tubes, and nasal intubation should be avoided. The oral route is preferred. Question. What is a key concern in a patient with significant facial trauma? Answer. Airway compromise from swelling, bleeding, or disrupted anatomy. One should have a low threshold for early intubation and surgical airway backup. Question. What is the primary cause of cardiac arrest in trauma? Answer. Hypoxemia and hypovolemia. Question. What is the most common error in airway management during a trauma code? Answer. Failure to recognize esophageal intubation. Question. What is the cannot intubate, cannot ventilate scenario? Answer. The most critical airway emergency, requiring immediate cricothyroidotomy. Question. What is the role of an extraglottic device in a pediatric difficult airway? Answer. Supraglottic airway devices are often effective rescue devices in children. Needle cricothyroidotomy is preferred over surgical in infants and young children. Question. Why is cervical spine immobilization crucial during airway management? Answer. To prevent secondary spinal cord injury in the 2 to 5% of blunt trauma patients who have a cervical spine injury. Question. What is the effect of positive pressure ventilation on a hypovolemic patient? Answer. It can decrease venous return and cause hypotension. Be prepared to administer fluid resuscitation. Question. What is ventilator-associated lung injury? Answer. Lung injury caused by the ventilator, including barotrauma, volatrauma, and atelectrauma, which can be prevented by using low tidal volumes. Question. What is acute respiratory distress syndrome? Answer. A form of respiratory failure from inflammatory lung injury, managed with low tidal volume ventilation of 6 ml per kilogram. Monitoring and complications. Question. What is the most important monitor during intubation? Answer. Pulse oximetry. Question. What is the most important monitor to confirm endotracheal tube placement? Answer. Waveform capnography. Question. What is a normal end-tidal carbon dioxide value? Answer. 35 to 45 millimeters of mercury. Question. What does a sudden drop in end-tidal carbon dioxide indicate in an intubated patient? Answer. Possible displacement of the endotracheal tube, disconnection from the circuit, or a massive drop in cardiac output such as from a pulmonary embolism or cardiac arrest. Question. What is the carbon dioxide waveform called? Answer. Capnogram. Question. What is a common early complication of intubation? Answer. Right mainstem bronchus intubation. Question. What is a common late complication of intubation? Answer. Ventilator-associated pneumonia. Question. What is the most serious complication of a surgical airway? Answer. Bleeding. Question. What is subcutaneous emphysema a sign of? Answer. Air leak from an airway, lung, or esophageal injury. Question. What is the deep sulcus sign on a supine chest radiograph? Answer. A very lucent costophrenic angle, indicating a pneumothorax. Quickfire and advanced topics. Question. What is the 30-30 rule for rapid sequence intubation in shock? Answer. It means one should consider reducing the induction drug dose by 30% if the patient is in shock. Question. What is the double setup for a difficult airway? Answer. Preparing for intubation with all equipment ready, while also having a provider prepped to perform a cricothyroidotomy at the same time. Question. What is the role of apneic diffusion oxygenation? Answer. Using high-flow nasal cannula during laryngoscopy to prolong safe apnea time. Question. What is the Lemon Law for airway assessment? Answer. Look externally. Evaluate the 3-3-2 rule, Malampati score, obstruction assessment, and neck mobility. Question. What is the 3-3-2 rule? Answer. The patient should be able to fit 3 fingers between their teeth, 3 fingers between the hyoid and chin, and 2 fingers between the thyroid notch and the floor of the mouth. This predicts the ease of laryngoscopy. Question. What is the Burke maneuver? Answer. Backwards, upwards, right pressure on the thyroid cartilage to improve glottic view. Question. What is the definition of difficult mask ventilation? Answer. It is not possible for the unassisted anesthesiologist to maintain oxygen saturation above 90% with 100% oxygen. Question. What is the vortex approach? Answer. A cognitive tool for managing the difficult airway, focusing on achieving oxygenation through any of 3 non-surgical plans: face mask, supraglottic airway, or endotracheal tube, before proceeding to a surgical plan. Question. What is the maximum number of laryngoscopy attempts before declaring a failed airway? Answer. 3 attempts by an experienced operator. More attempts increase the risk of airway edema and bleeding. Question. What is the rapid oxygen insufflation ventilation technique? Answer. A method for pre-oxygenating apneic patients. Question. What is delayed sequence intubation? Answer. Using ketamine to permit adequate pre-oxygenation in an agitated, combative patient who will not tolerate a mask. Question. What is the target oxygen saturation after intubation? Answer. 94 to 98%. Hyperoxia should be avoided, as it can be harmful. Question. What is the target tidal volume for a patient with a pulmonary contusion? Answer. 6 milliliters per kilogram of ideal body weight, to prevent volatrauma. Question. What is the most common cause of hypotension immediately after intubation? Answer. Hypovolemia, exacerbated by positive pressure ventilation and the vasodilatory effects of induction drugs. Question. What is the ultimate goal of airway and ventilatory management? Answer. To ensure adequate oxygenation and ventilation while preventing aspiration and secondary brain injury, all with minimal harm to the patient. Thank you for joining us on this comprehensive question and answer session covering airway and ventilatory management in trauma and critical care. If you enjoy our content, please like, share, and subscribe to the channel. It's the Everything Surgery Podcast. Dissect the extraordinary.